All right, well, thank you guys so much for joining. This is actually really exciting. We're gonna go ahead and kick things off. My name is Dr. Brooke Pierce. I am one of the co-founders of Dizzy and Vertigo Institute in Los Angeles. We are an audiology corporation, and I'm gonna explain all of that to you in just a moment. So the reason you all are here is because either you or someone you love is actually affected by dizziness. And so dizziness is pretty complicated. So I'm going to start breaking things down. But our mission as specialists or specialists that work with dizzy patients should be clear. So our job is to help dizzy patients translate the complexity of these symptoms into real solutions. And you know, it's really important to work in a collaborative environment with a collaborative approach, working with patients' physicians, working with occupational therapists, physical therapists, audiologists, chiropractors, dietitians, the list goes on and on and on, to really manage and treat vestibular disorders. So I'm going to break down what an audiologist is because it means different things in different parts of the world. In the United States, I'm going to read straight from the slide because it's a little bit of a long slide, but it's a clinical specialist that's uniquely qualified in a comprehensive way to identify, evaluate, habituate, and rehabilitate those of impairments of the auditory and then the vestibular system. Audiologists are professionals who identify, assess, and manage these disorders of the auditory, balance, or other neural systems. So one of the biggest pieces of the puzzle when we get into dizziness is, what does it mean? Because dizziness really is an umbrella term. When we sit down with patients, we ask them to just go ahead and tell us how they're feeling, explain their symptoms of dizziness to us. And we get a whole slew of descriptions. Dizziness is the umbrella term, and underneath it is going to fall the actual description. So vertigo would be a spinning sensation, imbalance, disequilibrium, rocking, swaying, lightheadedness. We even hear walking on clouds, or that they feel very visually disturbed. So whether they're seated or you know, kind of watching things from side to side, it just feels like a big disconnect. Fuzzy vision, fatigued eyes, also a woozy sensation, even a floating sensation. Sometimes we hear it's sort of like an out-of-body experience, tendency to fall, unsteadiness, even a swimming sensation, hypersensitivity to really crowded or busy environments. So that could even be like at a basketball game or walking around the street, you know, on a busy sidewalk. And then also spatial disorientation. So really feeling that there's a big disconnect between where your body is in space and where you physically are supposed to be in space. So here's what gets extremely complicated. So dizziness is a symptom of everything. And so you're going to hear that throughout the day, that it's very complicated because it kind of sprinkles throughout specialties. So dizziness can exist from a cardiovascular component, from a neurological component, metabolic, vestibular, which we're going to get into a lot today, a visual impairment, psychological, diet and nutrition, medications or changes in medications, head injuries, drugs, alcohol, the list goes on and on and on. So I think these statistics are pretty fascinating, and the more education we get out there and the more that these stats become common knowledge, the more resources that we can all tap into. So a third of all dizzy patients are actually, when they're reporting to healthcare professionals, can be broken up to vestibular patients, or the inner ear is actually involved. So before I get too deep into it, I'm going to kind of high level the 101 discussion today, and then each clinician and physician that's going to be presenting today will take a deeper dive. But to think about all of those descriptions that I just went through, from cardiovascular to neurology, and again, the list goes on and on. A third of those patients are actually coming from the ear, from the vestibular system itself. So stat number 2 up here is pretty interesting in the United States, and it's very similar statistically in Europe and Australia and throughout the world. But our stats here in the States are 35% of people age 40 and above, which for us is about 60 million Americans, have experienced some type of vestibular dysfunction. So that's pretty wild to think how prevalent it actually is. And then with children, so when we're talking about the pediatric population, 1 in 20 kids in the United States are going to have dizziness or balance problems. So this is a pretty good rendition of what a lot of patients, will describe as dizziness or what their symptoms are. So again, it doesn't have to be a true spinning or a vertiginous bout or experience, a bobbing sensation. So, what does all this mean and why are you guys actually here today? And I think the simple answer to it is, we want solutions. We want to know what the next options are and how do we provide relief. So let's get into a little bit of the science, and we're going to kind of high level a lot of this. But one of the most important things to understand when we first get into the diagnostic testing is, are we looking at something that has to do with the central system? So when we're looking at the actual kind of the scary stuff, the brain stem, and the way the brain is processing information, or are we looking at something that is peripheral? Meaning that it's outside the brain and the brainstem. And in particular, when we're going through this discussion today, it's going to be how the vestibular system is involved. So before we take a little bit of a deeper dive, I wanted to just break down the ear, and we'll get to a schematic in a minute, but the ear has 2 parts to it. So there's going to be the hearing part of the ear, which most of us associate with the ear itself, and then the actual balance part of the ear. So the balance part of the ear is what we keep referencing, or what I keep alluding to, as the vestibular system. So it will start to make a lot more sense. The purpose of this kind of meeting of the minds here is not to take a deep dive into the anatomy and physiology, but really the functionality and the fix of all of this. So really differentiating between central and peripheral dizziness can be really challenging. So going back to that step one really is to rule out anything scary, any central causes. This is going to be your strokes, any type of TBI. So neurology is involved very heavily. Same with cardiology, making sure that we're not dealing with a situation that could potentially be life-threatening. So that's going to be the first stop for a lot of patients, is to be medically evaluated and any type of those scary etiologies ruled out. The second step is really going to be to determine if it is peripheral. So really looking at what the functional applications of the system are, and if there is dysfunction in one or even more of the peripheral system. So we'll get into a little bit of trivia. So when we start speaking about the peripheral vestibular system, just kind of think in your heads here, but I think this is super interesting, and this is going to really kind of speak to a lot more of the discussions we have throughout the course of the day. But does anybody know the major sensory organs that are in the vestibular system? So we don't have to go through, the names of them, but how many end organs are in the vestibular system? So there's actually 10, which is pretty fascinating. And you're going to hear a lot of discussion about why all 10 of those end organs need to be evaluated. But we have 5 on the right side and 5 on the left side. So let's break this down, because 10 total major sensory organs are going to be making up the vestibular system. So there's 3 semicircular canals. So we all have these in our ears. They look like little loops on a roller coaster. And those 3 canals are responsible for giving us the orientation of where we are in space, kind of the angular and linear acceleration, and then just overall sensation to gravity. So these end organs are very, very important, because you could be seated and moving your head up and down, and the signal that's coming from these vestibular end organs is giving our body the input it needs. There is significant involvement in how these little end organs interact and send a signal for our overall balance. So they make a very big wave with regard to our equilibrium, our overall balance, our posture, and then even keeping our head upright, even as we're kind of moving our head around or bending up and down. So if we dive a little bit deeper, I think this is a really cool schematic. Basically, it's telling us, or kind of breaking down, how complicated the balance system really is. So if we think of the vestibular system as like a little GPS, or basically telling our body where we are on a map, it's really important to see how the brain integrates all of that. So the brain is taking input from a lot of different sources. And so the vestibular system is one of them. The input from the eyes, the vision system, the joint, the position, and the actual proprioceptive input from our muscles, control of our motor skills, and our overall posture, all goes together. So there's basically three reflexes that are working seamlessly in the background. The first one is that reflex between the ear, the eye, the brain. So that's the vestibular ocular reflex. And it really does help with that gaze stabilization with head movement, and helps the eyes compensate. So when they're moving in different positions, when the head is moving in different positions, the eyes are correcting for that movement. The second one is going to be the vestibular spinal reflex. And that one really is responsible for the motor control and then just overall postural support. And then the final one is going to be responsible for actual kind of neck stability and overall head stabilization and position in space. So the brain's taking all of this in real time and processing it pretty seamlessly when we feel well. So I think what's really kind of one of the biggest questions we get from a lot of patients is, how do you even know that it's the vestibular system? How do you even know kind of what we're looking at? Because it is so complicated. There's so many different pieces of it. How do we know that it's not the heart? How do we know that it's not the brain? How do we know that we're specifically honing in on those 10 end organs? So really, it's pretty black and white when we look at things from an objective standpoint. Science and technology have come light years. Even in the last 10 years, we really are able to take the guesswork out of a lot of this. And so you'll see, as we get into some of the more complicated and comprehensive talks throughout the day, this is not it's not guesswork. There's no magic to this. It's black and white science with a lot of objective data and a lot of norms that we use worldwide, that all of us are using to make sure we know what the end organs are doing and what they're not doing. So clinically, when you're going into a clinic, there should be two kind of wheelhouses with regard to the discussion that you're having with your clinician. So the first one should be subjectively how you're feeling. So what did happen when the onset of this occurred? What is your case history? Was there a cause of it? What does the duration of your symptoms look like? How often is it happening? How severe is it happening? Are there triggers? What makes it better? It should be a very comprehensive discussion. It shouldn't take 5 minutes. It shouldn't take 15 minutes. It should be pretty comprehensive in the sense that you feel you're able to answer all of the questions that were placed on a lot of the questionnaires, and that you're able to articulate your story in its capacity. And it could take a long time, so that the clinician has a very good idea of what we're looking at. Now, from an objective standpoint, when we're specifically looking at the ear, so the vestibular system, the tests need to be robust in the sense that the clinician needs to understand with certainty what the system is doing and what those 10 end organs are doing. Now, previously, and when we speak with clinicians who are not in this space all the time, most patients will say, well, they either did, gave patients home epilepsy maneuvers to try at home, or Brandt Durafs to see if that helps, or maybe the patient Googled, or looked up on YouTube some videos, tried some exercises. It's really, throwing a dart with your eyes closed at a target. You might hit it, you might get it right, but at the same time, there is a big, big margin of error. So we take the guesswork out of all of this, really going beyond, trying to see what works, or giving some global exercises to see if it helps, and getting to the crux of what's really happening. So previously, I'm going to kind of go backwards forward, because previously looking at G, so kind of going through my slide here, G is actually going to be what most people associate with balance testing or comprehensive balance testing. It's called a VNG. So it's the video nystagmography, and it's actually looking at, it's a sequence of tests that it's a battery that we're looking at eye movement, we're looking at the actual body positions, and we're putting all of those puzzle pieces together to see how the system is processing input. It's a good battery, it's been used for a very long time, but it is absolutely a sliver of the pie when we're looking at the system comprehensively. So from an overall kind of global standpoint, we see a lot of patients that come in and say, you know, months and months and years ago, I had a VNG and it was normal and I was told to live with this, and that's all we can do. Maybe that's all we could do 30 years ago, 50 years ago, maybe. It's not the case now. So having a normal VNG does not mean that your balance system is normal. It does not mean that the vestibular end organs are functioning in their full capacity. So now we have tests that look at all 10 end organs, and we know that there's different etiologies or causes of dizziness that will affect different parts of the ear. And so again, just thinking through what the anatomy is, if different parts of the ear are responsible for different sensations, a patient who comes in, you know, complaining of vertigo where they're spinning might not have the same diagnostic abnormalities that a patient who says that they feel like they're rocking and swaying all the time might have. And so using the right tests to figure out what's going on with the system is really, really important. So when we get in and we're looking at the vestibular kind of diagnostic story, we want to hear what patients are noticing, but we're kind of very quickly triaging the patient. What tests are they going to need to rule out the part of the ear we're suspecting is causing the problem, or rule in the asymmetry or the weakness that we're suspecting? So it's really, really important to have the tools at your disposal. That's why comprehensive vestibular labs are very, very important. Dabbling in dizziness, or clinics that kind of do it on the side, where it's sort of like a side hustle where they'll see you, they'll do it, but they don't comprehensively evaluate or have the right tools. It might work for some patients, it just doesn't work for most. And so I'm going to go through the battery here, but the first test is a comprehensive rotational chair. There's quite a few rotational chairs used worldwide. The rotational chair that we use clinically is it's called an eye portal. And the reason we really like this piece of equipment is because of the sophistication of the actual camera, and then the actual frequencies and capability of movement of the chair. And so that's really important because the balance system is super complicated. It moves very slow and it moves very, very quick. And so whether we're working with professional athletes that have very, very quick reaction times, and their system it has different norms than your average person, you know, walking down the street, it's important to be able to evaluate them at very high or super thresholds. One of the other tests that we use clinically is going to be VEMP testing. And so a comprehensive clinic is going to have access to VEMP testing, which is going to be looking at specifically the otoliths, or a part of the ear that's responsible for that gravitational pull and linear acceleration. The other pieces of the puzzle are going to be looking specifically at Menieres, or changes in the actual composition of the ear and the signal that's coming from different parts of the ear. So there's testing called an ECOG, and then there's additional testing called auditory brainstem response testing. So these need to be included in the vestibular lab's ability, or the vestibular lab themselves needs to have access, or that clinician needs to know where these tests are available, so that if they are deemed necessary, that you're able to dig into them and really allow your physician and your clinicians that are working with you an idea very definitively of what the system is doing. Diagnostic testing, as far as audiological testing, is going to be referring to the actual hearing part of the ear. So looking in the ear itself, looking at the middle ear cavity itself, looking at how the actual nerve with regard to hearing and processing of that sound is occurring is important because of how the balance end organs and the auditory organs basically live in the same space or same vicinity, neighborhood. And then, so that piece of it is going to be an important piece of the puzzle. Going back to the balance, so the last couple pieces of the balance puzzle with regard to diagnostic testing are going to be computerized dynamic posturography, which we tell our patients it's like the cliff notes of the balance testing. So it's looking at, from a functional standpoint, how you're standing, and then how your brain is taking in the muscle input, the visual input, and then the signal coming from the ear. So those are really, really important pieces. And then the last one on here is a clinic favorite, just because it's pretty simple for patients to tolerate. It's going to be video head impulse testing. It's a really, really lightweight set of goggles, very, very tiny, very quick head movements. And we're actually taking calculations of the eye movement. And so a lot of clinics, this is one of our newer pieces of technology for a lot of clinics, just because we're able to do a lot of the testing and evaluate the system when it's working without making patients feel ill most of the time, which you might have heard with like the VNG during caloric testing, where they're putting, you know, the water or the air in your ears. So long story short, I know this was a long slide, but it's an important slide because what we see a lot of times is this piece of the puzzle just kind of like goes up in smoke. You know, you get a VNG or you go to an urgent care and you're kind of told, I don't know what it is, it's probably vertigo, good luck. You can't cut out this stage of it. And this stage of it is so comprehensive and needs to be very robust. And if it's not done with efficiency and certainty, patients are suffering for weeks, months, and years. So this is my soapbox. I will spend a couple more seconds on this, because if the clinicians, and again, there's different specialists all throughout the world, there's teams of physicians, there's teams of audiologists, and different clinicians that are doing these comprehensive tests. These are the lifeline for patients. And this is the most important thing, because this piece of the puzzle tees up the actual treatment. What kind of treatment are you going to need? Is the ear involved or not? Or do you need to be seen by another specialist and pull in another group of specialists that are going to be able to help in that treatment plan? So these are some really cool pictures of the diagnostic tests. And so I think it's really important to understand how sophisticated a lot of these pieces of equipment are and how specific the actual calculations need to be. And so again, the eyes are actually the window to the vestibular system. And so a lot of the testing is done through cameras. So patients will be seated a majority of the time and moving some of the time. And we're looking at the eye movements and looking how the eyes actually move under these camera lenses. And so this test, kind of to the left of the screen, is going to be very common for a lot of patients. This is the VNG testing, where you're laying down and you're looking at dots and, you know, you're moving your head in different positions. Versus the middle is going to be rotational chair testing, where you're kind of snuggled in. You know, we always tell patients this chair has a lot bigger bark than bite. It's not as scary as it looks. You're really tucked in and secured for a reason, so you're not shifting around or moving. Your body stays in one position as the chair rotates very slowly and very seamlessly, but we're taking eye recordings. We're looking at how the eye is actually moving. And so it's really important to look at the system not only statically, where it's just laying there and resting, but also dynamically. What is it doing when it's working? Because if we're just looking at the system static, you know, where we're looking at, you know, like a VNG battery, that's not the real world. If you're moving around and you're saying you're having difficulty when you're riding in a car, or you're going to get your kids from school walking down the hallways, or you're on the field during football practice, that doesn't translate until you actually task the system and make it work. So that's really important to look at the system dynamically and then, you know, statically. The top right screen is going to be the video head impulse testing. So again, the camera's a lot different. It's really tiny. The head movement's very rapid. It's very quick, but it's usually a patient favorite too, because it's pretty simple. It's pretty seamless. The rest of the testing here is going to get into a few. So I'll go left to right again. So to the left, there are multiple computerized dynamic posturography platforms now. This one is an older version that's used to basically visually challenge the system, and then you're on a force plate or like a moving floor. And there are advanced versions now that also integrate virtual reality to really get a good snapshot of how your system is processing and taking in visual information, and then how that actually makes sense with how your body moves and sways. The top one with the little button is actually looking at kind of subjective vertical upright, and that is going to be a subjective test of how you perceive things to be in the environment. So again, it's looking at the otoliths, or the part of the ear that's responsible for that gravitational pull. The bottom screen to the right is going to be the actual VEMP testing, and additionally any type of electrophysiological testing. So anytime we're using electrodes on you, or anytime that we're actually trying to pick up frequencies coming from the system. They're pretty simple to do. This one particularly is looking at the VEMP testing. So again, it's sort of like getting a bad facial, where you'll get scrubbed, you'll get electrodes on, and then you basically are just gonna rest, and we're gonna take the calculations from the system. The top right is just a really cool picture. We think it's pretty cool, but your eyes are going to be on the screen when we're doing a lot of the rotational chair testing. So we've got these huge kind of snapshots of what your eyeballs are doing on the screen, and it's very, very detailed and very specific. It's taking tracings of your eye movements, and then it's actually putting it into the software and making calculations in real time. And so it's extremely calculated. And again, there shouldn't be any guesswork. You either have a vestibulopathy or you do not. The system is either functioning at thresholds that are normal or compared to normative data or not. And again, this is not a general rule. This does not apply to every single person in every situation, but there's a lot that goes into this that's well beyond the V&G. So there's a lot that we can actually get from all of this data. And the way a lot of clinics work with regard to kind of the handoff of patients should be pretty seamless. So patients where we see have the most difficulty are bounced in between different specialists, and there's not this continuum of care. And so patients who are medically cleared on the front end receive diagnostic testing comprehensively in the middle, and then are transitioned to therapeutic application that takes those thresholds from the diagnostic testing is where it all comes together. To skip one or to go in the reverse order is not going to work. Again, just getting, handout exercises or just skipping to a rehabilitation program, it works for some, but for most patients, understanding what the right ear is doing, what the left ear is doing, what the etiology, the actual cause of this is, what the current functional application of the system is, and then moving from that point is where this all kind of gets strung together. So looking at all of this and going through all those tests and then sitting through all of the diagnostic testing, if necessary, should give us a really good snapshot of what's happening. So not every patient needs every test. And again, it could be very quick where the patient's coming in, they're going through repositioning maneuvers and they move on with their lives, or it could be very comprehensive. And so here's kind of a rundown of a lot of different pieces of the vestibular puzzle. You're going to get a lot on this today, and so I just wanted to give an overview because the physicians and the clinicians that are presenting on this, you're going to get some really good meat from the presentations. So the first one is going to be BPPV. So that is positional vertigo or benign positional vertigo. The second one is going to be labyrinthitis or vestibular neuronitis, chronic versus acute vestibulopathy, migraine associated vertigo or vestibular migraine, visual vertigo or visual disturbance, Mal-de-Barkmont syndrome, dizziness that can be age-related or imbalance, and even superior canal dehiscence syndrome or a paralymphatic fistula. So just a few, I'm going to pick kind of some of these top disorders and give you a little bit of an overview. And you're going to take a deep dive later in the actual day so that you can kind of understand what this looks like. But benign positional vertigo, or BPPV, you've probably heard before. It's been described as rocks in your head or crystals. And the long and short of it is that there's literally rocks in your head. We all have them. You want them. They're supposed to be there, but they're not supposed to move out of the position they're designed to live in. And so when they come out of the position they're supposed to be in, they cause a very, very intense but brief bout of vertigo. So it's like a true spinning sensation. It's lasting usually less than a minute. So usually it's going to be seconds up to a minute, and then the symptoms stop. And so literally the symptoms stop when that little calcium deposit or the rock or the actual crystal moves back to kind of a resting position. So I'm not going to get too into this, but you're going to get a whole talk on this today. That's extremely interesting. This type of vertigo sort of is like a wave a magic wand and goes away kind of vertigo for most patients. So upwards of 85% of patients will get a treatment or two and move on with their lives. So it is a pretty simple treatment for a lot of patients. And same diagnostically, it's pretty easy to see in patients. The eyes move a really funny way, so you can see on the schematic. They don't just move side to side or up and down. If you're dealing with the back canal, so the bottom canal is called the posterior canal, the eyes torque. They kind of move in this really funny torsional fashion. So for us, what we're looking at is nystagmus. We're looking at eye movement. All of our testing is done under goggles. It's really important for our clinic and for a lot of clinics worldwide to use goggles because we can figure out which canal, right or left, up or down, or even the side canal involvement. And then it helps us with the treatment too. The fun fact that I wanted to put on here is that residual symptoms after BPPV can actually last for months. And so we're going to have a pretty interesting talk on this later, but it wouldn't be the spinning that's happening any longer for patients. It would be any imbalance, unsteadiness, disequilibrium that they still are having after the treatment of the spinning. So the other one that we're going to kind of touch on is going to be vestibular neuronitis or labyrinthitis. So the main difference with this is really going to be, is the hearing affected or not? And so with this, a virus basically enters the system. And with labyrinthitis, you're going to have a change in hearing and a change in balance. And so having a comprehensive audiological eval or looking at the hearing is going to be important. Because sometimes patients are coming in and they say, it feels really full in my ear, or it feels like maybe the right ear hears differently than the other. Taking the guesswork out, is it fullness in the ear or is it change in hearing of the ear, is going to be really important. The treatment for this is really going to be medical management, and it's very important that the physician is involved with regard to medical management of the patient initially. In most patients, a couple of weeks, they move on with their lives and they're fine. Sometimes they will need medical intervention that's going to include vestibular rehabilitation therapy in addition to any type of steroid or antibiotic regimen that the physician is going to recommend. But for the most part, most patients will get it. It's pretty nasty for, a couple of days or a couple of weeks, and then, they're completely resolved. Little fun fact on here again is going to be cold and flu season is actually the busiest time of the year for labyrinthitis and then vestibular neuronitis. So Menieres disease is going to be another one that I just wanted to touch on. Again, you will get a talk, but some of the hallmarks of this I think are really important to understand, because there are so many patients that will say, well, I have vertigo. Okay, what does that mean? Or I have Menieres disease. I was told I have Menieres disease. And so when you go in and actually try to understand what that means, and we go through, okay, do you have pretty intense bouts or drop attacks of vertigo that are lasting for hours at a time? Do you have roaring tinnitus where your ears really just kind of sound like somebody turned on a fan, or it sounds like just a whole jet engine kind of turns on? Do you have fullness in your ear or ears where you feel like it's literally full of liquid or fluid, or you need to pop your ears? And do you have fluctuating hearing loss? Is your hearing coming and going? Is it getting worse over time? So those all need to come together. Being evaluated by a neuro-otologist, or even a physician in general, that's going to be able to just allow you to kind of say what your symptoms are and kind of go through the boxes. Is it the vertigo? Is it the tinnitus? Is it the fullness in the ear? And is it the actual fluctuations that are documented over time of hearing loss? If it's one or none of those, it's not Menieres. And so that's why it's important, again, to get the diagnostic testing. The ECOG testing and the audiological testing are very important for this patient population. So another fun fact is going to be Vincent van Gogh actually suffered from Menieres. So migraine-associated vertigo is going to be, this is such an interesting, very, very interesting etiology, and there's so much work going into this right now with regard to research and treatment and how these patients are managed. So migraine in general is one of the most debilitating chronic conditions in the United States, and that's pretty similar throughout the world. And so what I think is one of the most important things to really note is that 40% of patients with migraine will have a vestibular component affecting their balance or dizziness. So that's really important to understand, because a lot of times when you say migraine, sometimes patients will say, well, I don't have headaches. I don't have headaches. Understanding what migraine associated vertigo is and what it's not is very important. And so again, you're going to get a very comprehensive talk on this, but this is a very exciting piece of the puzzle as far as research and treatment that's coming out, because patients are starting to really understand what this management looks like and what it looks like to be managed medically, from a medication standpoint, from a supplement standpoint, but also dietary, what it looks like to be managed, from a trigger identification, and working with dietitians that are able to really go through and really make sense of anti-inflammatory diets and what specifically the triggers are to that specific person, which is really important. So the diagnostic criteria for migraine patients is, going to be a family history. Most patients have motion intolerance, even in childhood. They're presenting with vestibular symptoms, and there's a whole kind of checklist or tick list that's followed, when you're in front of the right specialist who understands what migraine associated vertigo is. And if they don't understand it, getting you to the right specialist that's able to really go through and manage that condition for you. So with all of that being said, you'll hear, or maybe even you just want a magic pill. You want this to go away. You want it to be better. You just want things to kind of go back to how they were before this all started. And so initially, especially in the States, when patients are going into urgent care, they are screened for stroke, making sure that they don't have any stroke. Usually they're getting imaging that's going to include a CT scan or an MRI. And then if that's fine, they're kind of sent on their way. And so, not to keep things, too global, but for the most part, making sure that there's not anything medically that needs to be, evaluated quickly, or anything that's life-threatening. And if it's not, here, take a meclizine or take an antivert or take something that's going to make the symptoms go away temporarily. And so what works very, very short term, and the use and the design of a lot of these vestibular suppressants is short term. You're supposed to use them short term. They're supposed to help short term. And so they're not meant to be used for weeks and weeks, months and months, years and years, decades and decades. It doesn't work that way. Your system doesn't, it doesn't happen with regard to recovery that way. So the brain can't fix what it can't see. It can't habituate. It can't adapt. It can't compensate unless it's getting and receiving the error signal itself. And so if you're taking the meclizine, or you're taking the anti-motion or basically a vestibular suppressant, an anti-vestibular medication, It's like a spring. You're pressing down on a spring long term. And so one of the biggest things, once that diagnostic testing is done, is to get the rehabilitation going. And so that's really working with the right specialist, whether it's the vestibular specialist, that really knows how to do this, or finding the vestibular specialist in your area that knows how to do this is going to be very, very important. There's going to be a talk later on the time frame of all of this and why that is so important. You don't want to sit around for weeks and see what happens. You don't want to sit around for months, let alone years. Your system needs to be just kind of guided and moved in the right direction so that the rehabilitation process can happen. So we've got standard vestibular rehab therapy, just the 101 of all of this, is going to be kind of tried and true. It's very, very effective. It works a majority of the time for patients as long as it's done consistently. And it's usually ran through three kind of systematic ways of introducing the exercises. So it's going to be adaptation exercises that are designed to address the symptoms of gaze instability and with head movement. And the point is really helping your brain adapt to seeking these visual targets within, the real world, and helping your brain starting to integrate those processes again properly. The next sequence is going to be substitution exercises. So they're really designed to address symptoms where the impairment of the balance or the actual system itself is no longer capable of using all cylinders. And so it's really helping the brain seek new input and use new input. So it's either going to be, reweighting the system from a visual standpoint or a sensory standpoint, because you're not getting what you need from a stimulation standpoint coming from the ear. And then the third one on here is going to be habituation exercises. So they're really designed to provide temporary symptoms. So you will be triggered when you do these exercises. So again, trying to provide like a little mirror to the balance system. So helping the brain see when it needs to fix and see what it needs to actually work through and process. Because the brain is very plastic. It wants to fix itself. It's just these sequence of exercises ramp up just enough, again, based on the thresholds that you were able to tolerate or were able to tolerate initially, and then building from that, sort of like if you're going up a stairwell, you want to build and then you want to plateau, build, plateau, build, plateau. What happens a lot of times is if you are, playing Dr. Google and you go online and you just find a sequence of adaptation exercises or substitution or habituation exercises, and you haven't been evaluated by a vestibular therapist and you're not working with a therapist to go through and really basically know when to gas and break the system. When do you push the system so that it's growing, it's learning, it's changing, it's getting stronger? And then when do you gas it where you need to pause, relax, and allow the system time to rest and recover? And so working with a specialist, it's really, really important, because that's the end game, making this efficient and effective so that you can move through as quickly as possible. So here's just a couple quick little snapshots of patients who are performing those substitution, adaptation, and habituation exercises. Pretty simple. You'll find them, there's all kinds of books and all kinds of resources, but from a physical therapy standpoint, from an occupational therapy standpoint, and a lot of other specialties that are working in this wheelhouse, they're pretty classic and pretty standard exercises. When you move from one to the next, it's based on a lot of your subjective input and then objective data, what you're able to tolerate. There are a lot of clinics that are continually monitoring, so it's important, as you move from one system or one sequence of exercises to the next, what is the graduation look like? Does it mean that you're scoring lower on certain questionnaires, the DHI, for example? Are you starting to present with different input with regard to your SVV or SVH input? Are you scoring higher on your computerized dynamic posturography? What does this look like as the process is moved through? And each specialty will be using different kind of rubrics to move patients through with regard to next steps and continued improvement. So the next one on here is really going to be how technology is moving a lot of this forward. So instead of, holding a card in front of you or putting your thumb in front of you, which is a very viable and a very helpful option, technology is advancing significantly. So whether it's clinically or with home use, patients are using a lot of optokinetic stimulation. They're using a lot of virtual reality application. There are a lot of companies now that we're using that are actually specific for vestibular rehabilitation. And so it doesn't mean that we're putting VR goggles on and helping you, get used to riding a roller coaster and trying to make you sick while you're watching, videos through the VR. That's not it. It's literally providing the bridge between where your system is functioning and what your system is functioning, and the capability of your system's functionality and where it needs to be in the real world. So the real world has tons of sizes and shapes and colors and thresholds and lights that you're constantly being exposed to. But through a lot of the virtual reality rehabilitation programs, your system in the VR is very slowly and very systematically being exposed to a little bit more each time, so that you're actually able to bridge the gap between where you were, where you need to be, and the VR does a pretty phenomenal job of getting patients there. And then a lot of the rotational chairs and a lot of the posturography equipments are being used therapeutically too. So patients are not only dynamically, in there with their movement or in there during the diagnostic testing, but then again being worked through and helping the system habituate along the way, so that those thresholds are increased and they're getting improvement overall session over session. The home applications should duplicate a lot of what's happening clinically. This is just a couple quick little snapshots of some of the virtual reality that we've created in our clinic. It should be fun and simple and crisp and clear. And so a lot of it is done through optokinetic stimulation. Some of it is done through a lot of visual desensitization, and a lot of it's done through gaze stabilization, the simple stuff that we're doing even with thumb movement. So it's really important for patients to understand that this is a process, and there's a very systematic way that this process and the brain compensates, which is important. So kind of the take home is going to be that dizziness affects all of us at a certain point, whether it's directly or indirectly through a family member or friend. And so it doesn't matter how rich and famous you are. It doesn't matter kind of how high level your functioning is, or how low level or slow or kind of sedentary your overall daily tasks might be, that this is something that is extremely debilitating when it hits, but there are science and solutions that are at the ready. And so that's really what we're excited to present today and kind of move through today. One of the most important things, just a quick little synopsis, you're going to get more of this, but it's going to be, how on earth do you find a vestibular specialist that is going to know that this is more than the VNG? This is not, circa 1970. This is more than the VNG, and we are able to test more of the system in a very comprehensive and very specific way. So you want to be working with a specialist that specializes in dizziness. And so if the first stop is working with your primary care doctor who does not specialize in dizziness, asking him or her who in the area does specialize in dizziness. And it should be a day in and a day out dizziness specialty. It shouldn't be dabbling. And again, it really shouldn't be a side hustle. It shouldn't be something that you do because you kind of remember how to do it, or maybe, you want to get into it. You got to dive into this because there's too much at stake with regard to time frame and loss of quality of overall just life. So it's also important to have advanced equipment to really be able to evaluate the entire balance system. Using things that we did, again, kind of going back to that 1970, time frame, we've come light years ahead. There's no reason why we're not able to advance and look at the system comprehensively. And if the clinic that you're at does not have capability to do it, who in your area does? Because there are very comprehensive balance clinics throughout the world that have a passion for this and a real knowledge and a real investment, not only financially, but in the overall outcome of patients. So finding those people who not only put the money down to make this right from an actual, diagnostic equipment standpoint, but understanding how you leverage that for patients and how you help the overall outcome, which is getting people better. Working in a team is huge. Not having a one-stop shop where, oh, if it's not the ear, I don't know, good luck with that. Who are the specialists in the area? If there is some neurological concerns, where is the neurologist that you're going to be working with, or who are they? If there's a cardiologist that needs to be involved, if there's a dietitian that needs to be involved, an occupational therapist, your physical therapist, all of this needs to go together. And it would be very, very unlikely. I've never heard of one person that can do all of that. So it's really understanding, is your specialist, do they work with part of a team? And if they are collaborating within their community to make sure that the patient is getting what they need from beginning to end. Another important thing, and you have to do a little bit of digging on this usually, but really understanding, even when you're speaking with a lot of the support staff, is that professional active in associations that are continuing their knowledge, and are they current in, their research and treatment? And I think it's a right as a patient to understand, are they staying current? Because technology changes very rapidly, and the treatment protocols and processes change very rapidly. So just to claim that you're in this space, or just to, work with patients that you think you can help with dizziness, isn't best practices for the patient or for the professionals who are really, kind of helping gear and steer all of, this funnel towards one direction. And so the other thing, and the final thing, is going to be explaining your treatment options and how it works. There's a lot of different ways that this can be applied. Not all patients like virtual reality. Not all patients like, thumb movements that they're going to be doing for gaze stabilization, based on home printouts. Not all patients want to follow up with a dietitian. Not all patients want to follow up with, lifestyle modifications or going through what potential triggers could be. So understanding what the recommendations are, and then what is going to be applied or be applicable to your specific situation. So the take home is really going to be, if you're just looking at a small picture, right? So the picture to the left is going to be a little tiny little snapshot. If I'm just looking at the VNG testing from a diagnostic standpoint, or I'm just talking to the patient for 3 to 5 minutes about their dizziness and trying to really quickly understand what's happening, am I getting a full picture? And so I don't know, I would have guessed maybe it's like a little boy's haircut, or like the top of a little boy's head. With the long and short, if you take a step back and you start to look at the big picture, there can be so much more involved. And so not just doing the VNG, not just doing a quick get up and go, you have to look at the patient comprehensively to make sense of all of this. So with that being said, I am really excited to kick this off. I think it's going to be a very informative day. You can always reach out to us if you have any questions. Our info's at the bottom. Our email is info@dizzyandvertigo.com, or on our website at dizzyandvertigo.com.